Welcome everybody to the continuation of our series of webinars on COVID policy responses. My name is John Silas. I'm the coordinator of the London hubs of the European Observatory, and I'll be facilitating today. This was actually meant to be the last webinar of the year, but much like the pandemic, it continues into next week. And so next week, just to flag, we will have a surprise extra webinar on long-term care. But today we're focusing on the Visegrad countries. So the Visegrad countries are, as you all know, Czech Republic, Slovakia, Hungary, and Poland. And this is a really interesting group of countries to be looking at, I think. Because when you look back, if we go back a few, you can register next week in the normal way. Sorry, if we for the session next week. If we look at the Visegrad countries, we see, of course, when we go back to the first wave, that that these countries were largely unaffected. So while the rest of Europe was really struggling to contain the virus, these countries seemed to basically be impervious. And there was a lot of speculation at the time about whether this was due to some sort of characteristic of Central European countries, perhaps the high rates of BCG vaccinations. But as we'll discuss later this morning, what was likely to be the main reason that we didn't see such a big first wave in the region was that all of these countries were really quick to respond to expert advice. They locked down quickly, they mobilized very quickly, and this really helped save them in this first wave. But here we are, fast forward through the summer, things were mostly fine. And we get to the fall, and all four countries have seen massive increases, especially compared to the spring, in their cases, increases in deaths. And this raises a lot of important questions of, well, why? What has changed between the first wave and now? Have policymakers stopped listening to the experts, or have they started listening to different experts? Has their ability to respond, their capacity to respond, sort of run its course? So this is what we're going to be talking about today. We have a great group of speakers from all four Visegrad countries, as well as a discussant from WHO. But before we get started with that, I'm going to pass it over to my colleague, Erica Richardson from the Observatory, who's going to talk a bit about the Health Systems Response Monitor, which is the tool that we use to generate all of this evidence so that we can keep track of what countries are doing. So Erica, over to you.
The Health System Response Monitor, the COVID-19 Health System Response Monitor, is a collaboration between the European Observatory on Health Systems and Policies, the World Health Organization Regional Office for Europe, and the European Commission. And what it does is that it's an online tool that gathers together and organizes and shares information in four key areas using a network of academics, ministry sources, WHO colleagues as country correspondents. So the four key areas where it shares this information is in country information. So collecting, checking, updating profiles on most of the countries in the whole of the WHO European region. It also supports comparisons across countries. So as you can see, there's the homepage on the right of the screen. You can go in and you can select your countries. You can select this particular policy area that you're interested in and compare across countries. It also guides users to the most reliable international COVID-19 data, also the most timely data, by offering all these links in one place, as well as articles on wider public health initiatives and good practices. And it also provides analyses of key themes that cut across countries, that provide snapshots of different policy responses and setting these initiatives into context. And this is very much the basis, these cross-cutting analyses is very much the basis for this series of webinars. So these cross-cutting analyses are basically pulling out these sort of different narrative threads as either as the editors themselves see them emerging, or most often in response to questions from countries or from WHO or the European Commission. In these analyses, it likes to give lots of rich examples and good practices, but also links to key documents. And these updates come out as policy, practice, and indeed the pandemic evolves. So we also have a link to, we'll provide the link in the chat box, but we also have a special edition of EuroHealth, a special bumper, super thick edition of EuroHealth with lots of these cross-cutting analyses published as short articles. And there is a forthcoming edition of Health Policy, which will provide a much more sort of meaty academic articles too. And indeed, this there will be one on comparing across the Visegrad countries. Thank you very much.
So our first presenter is Olga Loblova from the University of Cambridge. She is a research associate in the Department of Sociology and any day now a Wellcome Fellow. So Olga, thank you. You have about 12 minutes.
Thank you very much. It's a pleasure to introduce today's topic on the responses to COVID-19 in the Visegrad region. And as John said, the Visegrad countries are similar to the wider Central and Eastern European region in that they are having a much worse second wave than the first wave in the spring. So on the slide, you can see the 10 Eastern European EU member states in green or blue, depending on your screen settings, and the Western European countries bold in red. And sorry, the other way around. Western European countries in blue and Eastern European countries in red. And you see basically that in the fall, Eastern Europe has overtaken the West in terms of COVID-19 deaths. If we zoom in on the 4 Visegrad countries, so on Hungary, the Czech Republic, Poland, and Slovakia, we see that the number of new cases in the fall is practically incomparable to the numbers in the spring. You can barely even notice the first wave in April on this graph, actually. And you can also, you can notice a bit better, but the number is still incomparable if you look at new deaths. And if you looked at excess mortality data, you would see very clearly that the second wave is very deadly in the Czech Republic. And recently we've started seeing some trends in Hungary as well. So all 4 Visegrad countries had similar policy responses to COVID-19 in the spring. They locked down very quickly when they had much fewer cases of COVID-19 than Western European core countries. They mandated face masks at a time when the WHO was actually advising against them. There was, the Slovakia was actually, as far as I know, the first country in Europe to mandate face masks indoors and outdoors, or outside of the home. And there was an impressive civil society response as individuals and companies took out their old sewing machines and started making cloth masks at home, as private firms, for instance, in IT, started working with governments to collaborate on solutions to COVID-19. Then the country's responses diverged somewhat over the summer. You can see this in the Oxford Government Response Stringency Index. The main difference is, you can see that in the summer, the 4 countries relaxed quite a bit, relaxed measures. But that there are still differences between them, and the main differences basically concern rules on face masks and limits on large gatherings. But overall, the Visegrad 4 countries relaxed measures more than in the West, if you compare them, for instance, to Italy. Now, in terms of the government response to COVID-19 in the region, there is one cross-cutting issue that really stands out, and that's capacity. You can call it policy capacity or state capacity or government effectiveness. To me, these are all similar terms to describe the same thing. It all comes down to the capacity of a country to design and implement effective public policies. find and implement solutions to the problem that we are facing. And this is what I'm going to spend the rest of this talk on. So in the spring, it seemed in Europe, somewhat also in the world, that the lower the policy capacity, the better the COVID-19 outcomes, the lower the death rate, basically. This is a figure from a political scientist from a spin-off of a paper that he published as a preprint in April, at the end of April. And you can see basically that the lower the policy capacity, the higher than the deaths, the slower countries were to close down. This is what John said at the beginning. You can clearly see this in Eastern Europe. But if we were to redo this graph today, well, in all likelihood, we would find that this no longer holds. And one reason for it might be that the capacity to declare an unprecedented lockdown, especially when you have a frightened population, a population whose only frame of reference is Bergamo and overflowing hospitals in Italy, is very different from the capacity a country needs to manage a pandemic day in, day out over the course of months or even years. And this capacity, the longer term capacity, the more sophisticated capacity, includes, for example, the ability to put in place a sufficient testing system. This is how I draw a COVID-19 swab and a tube. We know that the Visegrad countries are testing less than Western Europe, much less than the Western Europe, and they have had alarmingly high positivity rates, over 30%, sometimes over 40%. And this may be because there are not enough labs. This is something that you might actually think if you think poor countries maybe they don't have sufficient lab capacity, but actually it might be also because of bottlenecks in the testing process before individuals even arrive at a testing site. So, for example, the Czech Republic only uses about half of its declared laboratory capacity, and Hungary has also seen fluctuations in daily test numbers that are difficult to explain just with lab capacity alone. Each of the countries actually has its own idiosyncratic reasons for why testing rates are so low, but at the end of the day, this justifies lower capacity to design and implement an efficient testing system. Another example of capacity limitations is the capacity to put in place contact tracing systems. The Visegrad 4 countries have inherited a network of decentralized public health offices from 1999. From before 1989, which have been responsible for contact tracing as a rule in many Eastern European countries. So you'd think, well, the basis is there, right? But these regional or local public health authorities are generally understaffed, under-resourced, working on inefficient IT structures, working on using inefficient processes. And all of that became very obvious during the summer and fall as cases started to rise in the region. For instance, it became clear in the Czech Republic about late July, early August, that epidemiologists staffing these regional public health offices couldn't trace contacts effectively as cases rose above a certain threshold, and that threshold was relatively low. So there were about 400 to 600, 700 epidemiologists, and as cases started to rise above 400 or 600 new COVID plus diagnosed people per day, contact tracing basically collapsed. But it took until late September for the government to partner up with the private sector and bring in external contact tracers at a crucial time when the pandemic was just gathering strength and or force and growing very fast. And we see similar stories, reports of similar stories from the other three countries. that show clear capacity constraints when it comes to contact tracing in particular. Okay, finally, let's talk about expert capacity. There's a lot to be said about the involvement of scientists and experts in decision-making in the Visegrad 4 countries. But a lot of it is, in principle, similar to most other democracies. So, and maybe even non-democracies. Decision makers juggle competing priorities. They don't always follow the science, as people following the British debate would be familiar with this expression. If there ever is such a thing as following the science, because that expert advice isn't always unambiguous, united, and certain. But what is specific to the Visegrad 4 countries, and perhaps Eastern Europe more generally, is that decision-making has been quite opaque, lacking in transparency. And this mattered already for communicating the rationale for new measures and changing and evolving and developing measures to the public. So explaining it on the basis of scientific, of evidence and data and scientific advice has sometimes been a bit challenging for governments. In addition, this lack of transparency perhaps obfuscates a lack of institutionalized expert advice in policymaking. So 2 examples here. In Poland, some of the epidemiological modeling that the government relies on is compiled. So some of the epidemiological modeling that the government relies on uses data that is compiled by a 19-year-old high school graduate who was a high school student last year still, and other volunteers who started compiling and publishing data from fragmented local sources because they couldn't find a coherent source for the whole country. And perhaps Ivona can tell us more. In the Czech Republic, the first models that the government saw in March reportedly came from a private individual, a businessman who came forward to the government with an Excel sheet model, which is why you see a drawing of an Excel sheet on the screen. And Peter will talk about Hungary, and Martin will say a bit more about Slovakia. In Slovakia, for instance, the face mask mandate also reportedly came from a private individual's kind of amateur literature review on the efficacy of face masks. As I said, at a time when the WHO was advising against face masks. So this complicates the story a bit, because you can see that this kind of opaque decision-making without institutionalized expert advice can also sometimes lead to decisions that we would now, in retrospect, classify as good, right? But overall, the pandemic has led to questions about whether the Visegrad 4 countries actually have sufficient expert capacity within the public sector to cope with major unexpected challenges. And it's hard to prove that the expertise is there because of the lack of transparency. So we'd all like to believe that that institutionalized expertise exists and works flawlessly, but difficult to prove. One thing is clear: there is no equivalent in terms of stature or respect or influence to, for instance, the German Robert Koch Institute.
Olga, sorry, I'm just going to cut you off, even though this is it's very, very informative, and I think it's going to feed through the narratives of the other presentations. But just to follow my job of keeping honest to time, maybe just another 30 seconds to wrap up these last thoughts.
That's exactly what I need.
Perfect.
Fantastic. So it's not only about the lack of capacity, it's also about choices, right? Governments were making these choices. You can see in the Czech story about external contact tracers that this is possible. 200 external contact tracers hired existed at the beginning of September, 800 at the end of it. So it is possible to overcome capacity constraints with political commitment. And this is what will be needed now with supporting populations financially to actually increase compliance with measures. This is what will be needed with setting in place vaccination systems. So that's all for me. Thank you very much.
I'm going to pass it over now to Peter Gál from Semmelweis University in Hungary to hear if the narrative that Olga's put forth about capacity constraints and sort of this inability to perhaps sustain a response because of a lack of capacity, if this resonates in Hungary, or if there's new ways that the evidence is being used, or new evidence that's sort of supporting all of these decision making that's been useful going forward. So Peter, I pass it over to you.
So basically, I think we four countries are often cited as examples of bad politics during the pandemic, despite the success of the first wave. And I would like to refine this message with 2 points. First, that bad science can also contribute to bad politics. And second, that there is also good politics coming from our countries based on good science. And I'm going to show you 2 examples from Hungary to illustrate these points. The first one is about bad science. This is a very interesting case. During the first wave, Hungary freed up 50% of inpatient capacities by the 19th of April, and nobody understood at that time why, since the lockdown measures spectacularly hammered down the pandemic, and the highest number of hospitalized cases was on 4th of May, just above 1,000. And the government explanation was that prepare for the worst and hope for the best, but on what basis? And nobody knew at that time what this estimation was based on, or this measure was based on, but it later turned out that the prediction was based on a modeling team of the Ministry of Human Capacities. Basically, the government set up 2 expert groups parallel, one by the Ministry of Innovation and Technology, and the other is by the Ministry of Human Capacities. And this later expert group predicted 3.4 million cases by May as the best case scenario. But unfortunately, even though everybody understands that this was a very big overestimation or a prediction of cases, the data and the methods were unknown, unpublished. And this is just the press who shared this information with us. And of course, it is not just happening in Hungary. You can see the case of IHME and the Trump administration on the basis of IHME estimates, which the Trump administration downplayed the pandemic for the first wave very much. These are the sources of this case. And the second case is about basically good politics based on good science. And I think it is not that you have to predict very well what is happening, because everybody can make a mistake and data can be not sufficient to do this, but you have to be transparent about the methodology, and you have to make your data accessible for external experts to cross-check and validate, or even to criticize your modeling. And good politics is based on good science, and I can show you an example from Hungary. For this, the example of population movement monitoring during lockdown, the innovation of the Ministry of Innovation and Technology set up a so-called digital health and data utilization team at Semmelweis University, which I'm also the part of. We wanted to support the government using routinely collected data to show how effective the lockdown measures were. And we used anonymous mobile phone, so-called call detail records aggregated at the settlement level to track resting and moving devices as a proxy for population movement. We created 2 indexes, a stay-at-home index and a mobility index. All data were incorporated into a dashboard, and this particular tool was used by the government to refine population movement restrictions, because there were some anecdotal stories that Hungarians wanted to survive the lockdown by moving to their weekend houses at Lake Balaton. And in fact, our data showed that this sort of crowding did happen around Lake Balaton, and that prompted the government to authorize local governments, mayors, to implement extra movement restrictions. And as I mentioned, good science is transparent, both regarding methodology and data, and we already published our manuscript as a preprint and also our data set. You can find the link there. This is just a schematic figure showing how we put together this mobility and staying home indexes, and this is how the dashboard look like for these indices. You can track the green line for the stay-at-home indices. As a result, it went up very much as a result of the lockdown, and the movement went down. This is just a screenshot of the dashboard. It compiled all the different data, and this dashboard was on the basis of on the tablets of high-level decision makers, the Prime Minister as well. Okay, just to sum up, I think we four countries are often cited as examples of bad politics, but science can also be bad, on which it is not possible to build good decisions. Good science is transparent, both in terms of methods and data, and we four countries also offer examples of good politics based on good science. Thank you very much.
Thank you for sticking to the 5 minutes. So we're going to move very swiftly to Poland, to Ivana Kowalska-Babka from Jagiellonian University Medical College, who's going to tell us in 5 minutes about the Polish experience.
So in 5 minutes, as I told you, it's almost impossible to speak about the country cases. I decided to choose you selected examples of erosion of public confidence, public trust during the COVID-19 pandemic in Poland. Next slide, please. So as you can see on the slide, the first cases of COVID-19 in Visegrad group countries were at the beginning of March in Poland, 4th of March. And the situation during the springtime, summertime and autumn time was very similar. In Poland, the highest number of cases of COVID-19 were registered in October. It was 27,000 of cases in the 24 hours. So unlikely the other three countries, Poland decided to announce not the state of emergency, but the epidemic emergency, and then the state of epidemic. I think there was 3 key reasons why the government in Poland decided to announce this state of epidemic on the 3rd of March. The first, it was they tried to avoid a postponement of the presidential election scheduled on 10th of May, while the elections would have been prohibited during and 19 days after the end of the state of emergency. Then the declaration of the state of emergency imposes an obligation on the government to compensate the citizens for any economic losses caused by the introduced restriction. And of course, introduction of the state of emergency obliges the government to coordinate the responses with the local self-government in Poland. I just wanted also to show you the systemic approach about the COVID-19 in Poland. So capacity building, focus on hospital beds. At the beginning of the pandemic in Poland, the government, the Minister of Health, transformed the big hospital, at least one in a region, to the single infection hospitals. So at the beginning, as I told you, the hospitals were transformed into the single infection hospitals, securing a total of 10,000 beds. And the new strategy was announced by the Minister of Health in September. No more single infection COVID-19 hospital. They created the 3 levels of hospital security, with the 3rd level of the specialist treatment in the 9 biggest hospitals in Poland. GPs were involved in testing. And also, as you can see on the slide, the new field hospital at the National Football Stadium in Poland were built. And of course, there is a question on human resources, because as you probably know, there is a lack of the physician and the nurses in Poland. We are on the last place in Europe. Next slide, please, with the number of the physicians physician and the lowest number of the physician and nurses. So now I would like to show you these four examples of the erosion of the trust, public trust in government. So the Prime Minister during the summertime, during the time of our presidential election, encouraging older people, key electoral base for peace, this main governmental party, to vote in the election, assuring that the virus is under the control, and senior officials not wearing masks in public, visiting relatives in hospitals and others. So then the case of corruption in Poland, with the main role in this case played former Minister of Health, Łukasz Szumowski. He signed 2 contracts, one for the mask and the second for respirators. You can just read it here on the slide about this, because I don't have time to explain this. But what is really important, shortly after these scandals, the colleague of the Minister of Health, the Deputy Minister of Health, proposed an amendment to the special COVID-19 law, and during this implementation of the law, the legal protection against criminal liability to state official and heads of state-owned companies was just implemented. And COVID-19 database, I think it's very interesting because 1 month ago we have received from media information that the government relies the fight with the virus based on models created on the basis of data collected by 19 years old who does it as a hobby. So the effect of this is that the sanitary epidemiological stations have since been banned from publishing the data, and all data is now published by the Ministry of Health. Poland also stopped reporting data to ECDC. As you can see on the map, this is the green colors, so the data from Poland are not available. So also the testing rate has fallen, as well as the infection rate has fallen, of course. The last case of this erosion of confidence, you probably know it very good because it's a very well-known case. There are restrictions on the abortion law. The government using the epidemic to quietly pass controversial legislation. The end of October, the Constitutional Tribunal declared the right to abortion on the grounds of permanent and irreversible defects on the unconstitutional. This has numbers of protests until now, I would say. Experts regard this decision to be an irresponsible provocation of the citizens. I just conclude. I know I see you, John. So you can see this public attitude towards the pandemic and towards the implementation measures changed drastically, especially confidence in the government. The Poland is this green line, and the very last slide. So where we are going, I think it's the way beyond, because I think this confidence, this erosion of public confidence it's the signal to political changes in Poland. It will be my conclusion. Thank you very much for the attention, and thank you for the invitation for this presentation.
Thank you, Ivana. That was great, and I think you raised some really important issues about public trust and how that affects people's willingness to go along with the types of restrictions that are in place. We have one more country speaker, which is Martin Smetana. So Martin is from consultant at the Ministry of Education, Research and Sport in Slovakia. And so Martin, you have 5 minutes. We're behind schedule, but I think we will manage. If you keep it to 4 minutes, even better, but 4.5 minutes. Perfect.
Perfect. Thank you very much. So in my presentation, I focused on one of, capacity challenges, which is often overlooked, and it is capacity to collect, analyze, and interpret data. And I think that Slovakia is one of the best examples on how a potentially very good idea can end up in unintended consequences, and actually how a idea with great potential, well, was not fulfilled. What I'm talking about is our mass antigen testing, which kind of made Slovakia famous. And as you probably know, our prime minister at the beginning of October, without prior consultations, procured 30 million antigen tests. And he decided that we are going to have several rounds of mass testing of population. In fact, he managed to push and force 4 rounds of testing. The first one was a pilot, which began on 23rd of October. And then every other week, we had another round of testing. The pilot testing happened and was implemented only in the 4 most infected regions that time, but later on in the mass testing, everybody had to participate, but children below 10 and elderly about 65. In the second mass testing, which happened a week later, once again, everybody had to pass the test, but below 10 and elderly. But with the only difference is that the prevalence was set to 0.7% from the first mass testing, which meant that 45 regions had to be tested. And the third round of testing was not mass per se, because it was done only in 458 municipalities that had prevalence greater than 1% from the second mass testing. The tests were not compulsory, but if you didn't take a test, you would have to stay 10 days in a home quarantine, which basically meant that it was in this case compulsory, because I don't know anybody who would be willing to stay 10 days at home because he refused to take a test. Nonetheless, experts on epidemiology, statistics, economy, and other fields objected and had rather strong and public criticism of the prime minister's idea, and basically they were very critical of process and methodology behind how and why he chose certain regions. One of the biggest concern was that as EU Commission or WHO or even the manufacturers of tests suggested, the antigen tests are most effective when applied in certain conditions with the great prevalence of COVID. But however, our prime minister decided that he wants to test everybody. Well, our experts, including the epidemiologic consilium of a prime minister, suggested that it would be much better to apply only in regions with greater than 1.5 prevalence rate. Nonetheless, as you can see, what he chose was 0.7 and 1% in the third round of testing. Epidemiology suggested 1.5 prevalence. The chief analyst of National Bank of Slovakia suggested that 1.1 to 1.2% prevalence would be sufficient in order to get greater benefits than cost associated with testing. The epidemiologists, however, had more methodological problems, especially that in Slovakia we didn't do any validation test of procured AG tests, which, as you know, Liverpool did, and the results were suboptimal. There were no on-site validation tests, no after checkup test with PCR method, which means that everybody who got AG positive was just assumed positive without any checkup. And the IT system of antigen testing antigen testing samples or points was not connected with the overall public health authority system, which meant there was a lack of data. The reason why epidemiologists wanted to do a validation test was that without them and without a strong methodology, it would be very difficult to differentiate what impact antigen tests had, especially since Slovakia put in place more strict measures on 1st October and 15th of October, which was very close to the pilot and then first and second round of the tests. Furthermore, data became rather unreliable because public health authorities started to focus on antigen tests, and the PCR tests were for a couple of days put on sidetrack, and antigen tests were not reported on a regular basis for several days, which meant that we were to some extent in a black hole of information. The only pieces of information which remained correct were the occupancy of COVID beds, which are on green, and as you can see on the slide, the only confusing bit is that to the left is the 7th of December, which is yesterday, and to the right is the beginning of November, which actually is the date where the first mass testing took place. And as you can see, there are no significant improvements over the time. In fact, as you can see, we are once again on a steep increase in number of beds. Furthermore, it is, in conclusion, it is not surprising that the mass testing didn't work as expected, and this is for several hours of a debate. But my point is that wrong or imperfect data can lead to bad decisions. If this is supported by very bad communication, it can lead to very unintended consequences. For example, our prime minister claimed that if you take an antigen test, it is your ticket to freedom, you can do whatever you want, which actually probably led to a moral hazard. And as you can see on the graph here, which combines, because this is not, I think, published on ACDC or rolled in data, if you combine antigen test, including an PCR test, we actually today achieved the new record of number of cases per day, which means that 1 month after the mass testing, we have new records, both in terms of hospitalization and in terms of daily cases. What's more important, and this last bit, is that our experts actually suggested to make measures more strict. However, after the second round, Prime Minister eased some of the measures. For example, he opened churches. But antigen tests can be extremely effective if used in prevalent regions and on a frequent basis. And this is my last slide and last diagram, which shows 3 regions in Slovakia. The first one was the one which was in the pilot, and it had the greatest prevalence of incidents per 10,000 population at the day when the pilot took place. And as you can see, what impact the pilot and the mass testing had. So there was a significant decline because it was one of the most badly hit regions. If you compare it to, for example, Bratislava region, which is the green one, which had very low prevalence, it had virtually no impact compared to the measures we took or we implemented in mid-October. And there is one other region in the mid of Slovakia, which actually, even despite being tested, its prevalence increased. And why this happened is it is all because of lack of capacity to analyze, interpret data, and then act on them.
So we're a bit behind schedule, but that's okay. So we've gone through all the countries. We're going to have now Melita Jakob from the WHO European Center for Primary Healthcare in Kazakhstan, who is going to give us a bit of an overview perspective. We're a bit behind schedule, but Melita, I think you can still take 4 or 5 minutes to give your perspective, and we'll have a short question session. Thanks.
Thank you very much, John, and thank you very much for these wonderful country presentations. They were very rich, and I think we have all learned a lot. I have 4 points to make. I think the first one is that it's very important that we paint a balanced narrative when we talk about any particular country group. And the question is, are the Visegrad countries in any way different from the average experience in the WHO European region, which includes 53 countries? No country was really prepared for this pandemic in our region. And if we think of the countries that we always highlight with the strongest public health systems, the strongest tradition of evidence to policy or evidence to practice, either in public health or primary healthcare, they have actually had very big pandemic peaks, very much difficulties launching contact tracing or sustaining them into community transmission. And so I think we have to be a little bit gentle in our assessment of whether countries are doing well or not well. So I think the learning from this, however, is that we need to strengthen the system and document very clearly the weaknesses that this pandemic highlighted, including in the systems that allow us to connect evidence to practice, evidence to policymaking, or evidence to clinical practice. My second point is that when we talk about science in the context of the pandemic, we tend to focus on public health science. But how about economics? How about sociology? How about psychology? How about a more balanced treatment of science? And when one is a policymaker in such situation, should they only pursue the public health science rigorously at the expense of others? And I think this reaches back to social values and balancing the different social values, what kind of combination of values we want to pursue. But probably from a societal perspective, just focusing on the public health science, ignoring the others, would actually lead to perhaps big inequalities or tremendous mental health and social welfare costs. My third point about science is that let's be honest with each other. We love science, we work in science, But honestly, science is catching up with the state of the world. So is it really bad for a policymaker to go outside the box and try to experiment and innovate and try to do something else? Of course, there have to be safeguards if one follows that kind of approach and some kind of consensus or societal discussion. But I believe that it's important to also be open to innovation. And that leads me to my very final point. Now working in primary healthcare, we are documenting countries' experience in primary healthcare during the pandemic. And we're seeing enormous transformation in primary healthcare, enormous innovation by the providers, not because they were told so, not because there was science behind it, but they are reacting to a situation and they're accelerating some of the transformations that they were already engaged with. For example, putting out their multidisciplinary teams, increasing the role of social workers and nurses in response to the human resource constraint and in response to the combination of health, mental health, and social problems. Adoption of digital technologies, adoption of mobile outreach to the population are all trends that we are seeing that have really accelerated in the past few months. And to close on this, I think it's very important not only to think about current state of evidence and current state of science, but think a little bit ahead. For the next pandemic, it's very important that we document the good examples, and I was very happy to hear those. We're always full of bad examples of things that have gone wrong, but very important to seek out the good practices, the good changes, the good innovations, so that we learn from those experiences for building back better for the next pandemic. Hopefully not in our lifetime. Thank you.
Thanks, Melita, for the very balanced reflections. Can I bring everyone back so everyone's video camera on for some questions from the chat box? Erica, take it away.
Okay, I'm going to be super quick, and I'm sorry, I'm not going to be able to fit in all the questions. And I'm also going to be naughty because I'm actually going to start with a question from one of my colleagues, Marina Kara-Nicholas. And she asks, are countries with lower capacity, scientific capacity, more likely to follow the advice of international actors such as WHO, ECDC? I thought that was a particularly interesting question. Question from Lars Kieberg. How do you measure, or how do you quantify capacity in governance? That's governance. That's probably a question more for Olga. Then, was there a difference in government communications between the first and the second wave in all of these countries? That was actually directed at Ivona, but I think that's an interesting question for all the countries. What were the main issues behind the severity of the second wave? And what could be done differently, potentially, looking forward to hopefully not a third wave, but to the future. And then a nice general question, what's the outlook for the Visegrad 4 countries? So hopefully something nice and positive. Thank you very much.
Great set of questions, Erica. So who would like to take a stab first at some of those? Martin, please.
Thank you. I have one brief answer, and it can be nicely illustrated if you watched a press conference during the first wave and you watched the press conference of our Prime Minister in the second wave. During the first wave, he was standing there, and behind them there were the chief infectologist, epidemiologist, and a bunch of other experts. In the second wave, he's standing there by himself and other politicians, and this is the difference. It's not the experts making decisions in our case.
Peter, please.
Yeah, I just wanted to answer the question about government communication. I think the big difference, at least as far as Hungary is concerned, was that our Prime Minister wanted to avoid a lockdown at all costs, and this was because that was the message of the Prime Minister everywhere, that we cannot afford another lockdown because the economy suffered a lot. But I think the mistake here was that we relaxed almost all measures during the summer. Also those measures which had very little economic impact, very little impact on economic activity. And I think this is the real big mistake. I think even WHO said that it's not really a good idea to close schools and we have to have this as a last measure. So I think we expected that there will be a different approach for the second round to try to keep the country open as long as possible. But that wouldn't mean that you relax all preventive measures. So I think that was really the mistake in Hungary.
Thanks. Ivona?
So I think the situation in all Visegrad Group countries is the same with the governmental communication. During the springtime, the restrictions were really very high, I would say. During the summertime, in Poland especially, because the presidential election, we have this relaxing time. So we have forgotten, our government has forgotten about the pandemic and restriction. And now, of course, is the situation close to the springtime. So we are waiting what will be in the future. But our Minister of Health and our government announced that probably after, in the middle of January, the schools are going to be open for the first 3 classes of the grand schools. So I think there are the problems with the communication. And what I try to underline is this erosion of the public trust.
We've magically gotten back on schedule. So I wonder if we should sort of wrap up, maybe Olga, with some, as to make this a sort of a webinar sandwich, that you started us off and now you get to close it. What are your reflections? I think you came in with a slightly maybe pessimistic reality check of why things didn't go very well. Do you feel that there is hope for the future? Do you think that these countries will have learned from their lessons, or not their lessons, but learned really from the experiences of the second wave, and act differently in the new year? Or what are your thoughts?
So I wasn't meaning to be pessimistic, but obviously, if you look at the number of deaths and cases in the first wave and then in the second wave, I think the most important question to ask is why that happened. And I'd like to maybe thank Melita for saying, yes, we need to also celebrate the successes and learn from the successes as well. And speak to one thing that you said, Melita. You said public health is one thing, but there's all other kinds of sciences. And I think that's a very interesting empirical question to see in how far other disciplines were actually heard in the region and elsewhere in Europe or the world. Did do schools open because sociologists say so, or do pubs open because I don't know, maybe sociologists say so again? Maybe it's very necessary to open pubs for public mood. So that I think will be a very, very interesting empirical question, and we'll also see how that plays out in the future.
Thanks. No, so I think this was a good session. It really shows the challenges of sustaining a strong response over a long period, especially in this context with low capacity and eroding trust. And like in Hungary, for example, as Peter was mentioning, a country that relies more heavily than most other countries in the region on consumption taxes, it's very hard to take measures that can reduce economic activity. So yeah, I think this was really interesting. Thank you everyone for joining. Thank you to the participants. I want to flag, we have a survey that should be available momentarily, maybe when you click a button before you log out, but please fill out the survey to tell us what you like and don't like about these webinars so that we can customize them more in the new year. And that's it. So see you next week for our special additional webinar on long-term care, and have a nice rest of your day.